do you have any surgeons that specialize in breast implant bottoming issues? It's an interesting one, this. I remember when I was doing my big reconstructions in the NHS, and every now and then you get a problem, and you sort of you have these colleagues who you respect, who are very good surgeons, and you would often go to those for advice. And you don't really want someone who has got loads of experience kind of with that complication. I mean, because there's a kind of fine line between someone who's good, so therefore has a wide experience, versus someone who's got a large experience of managing complications, because you've got to think, are they got a lot of complications because they're not very good, so it's a fine line. So you want someone with a lot of experience, and I've done a lot of breast implants, but I'll be honest with you, I haven't got a huge experience of breast implant bottoming issues or bottoming out, because it's not really a problem that I see very often. So it's a weird one there. It's like, I don't know, if you find a surgeon who's got a huge experience of bottoming out, I guess they'll say, well, they're not my cases, they're other people's cases. So you might find that, but I'm not a surgeon who's got a huge experience, or at least specializes in breast implant bottoming out issues. What I will say is that breast implant bottoming out is a difficult problem. So basically, when an implant is placed, we always obviously try to make it placed perfectly, but it can be placed too high or too low. So if it's too high, and that's often when it's under the muscle kind of holds it up, you have to lower it. And to be fair, I have got quite a lot of experience of that. To be honest with you, probably I normally say to patients probably about once a year I have to lower a set of implants. I haven't been doing that many implants recently, but certainly historically I would say about once a year I have to lower a set of implants because they're too high, and that's usually when they're under the muscle, and you just have to do what's called an inferior capsulotomy. So you release the lower part of the capsule. You often have to release some of the muscle because the muscle's kind of holding it up here. Probably haven't divided it quite enough, and then let the implant come down. So that's an implant sitting too high. And as I say, I have got experience of that. The other problem you can get is an implant sitting too low. So it actually descends below the inframammary fold. The inframammary fold is the fold where the bra sits. And so if the inframammary goes down there, then that's sort of bottoming out. And that can be an issue, and it is more difficult. It's quite a difficult problem to create when there's kind of too much breast in the lower pole. Kind of weirdly, when the implant's sitting high, often patients, the look in clothes is okay. It's just when you take your clothes off, it looks wrong because the nipple kind of looks like it's sitting a bit too low. So cosmetically, it actually in clothes, it's not too bad. But bottoming out is kind of too much of the breast and the implant in the lower part of the breast, and it can be a difficult problem to create, to correct. You have to try and recreate the inframammary fold, which can be difficult. It's a lot easier to lower the inframammary fold than it is to raise it, because lowering it just means a bit of southward direction, dissection, and letting it sit at a lower place. But once it's been made too low and you have to try and higher it or raise it, you have to use quite a few either long-term dissolving or permanent sutures. Sometimes people use prosthetic meshes for this. It's in a situation where polyurethane implants are really good because they tend not to move. So once you've got them in the right place, they tend to stay in the same place. So there are measures that have been done, but it's quite a difficult problem to correct. And I'd be honest, full disclosure, I wouldn't say I specialize in breast implant bottoming issues. I'm not a specialist in it, simply because I see it extremely rarely. I've had it in very, very few patients, 1 or 2 patients in my career. So it's certainly not something that I would put myself out as an expert in. So if you're looking for someone who has a special interest in that, it's not me. But I don't know if anyone is really. I don't know if anyone would admit to being that, to be honest, because that means either they're getting a lot of referrals from other people, or they're getting problems with the implants they're putting in, I suppose. But I don't know, maybe you don't see it that way. Anyway, that's where I am.